Hello friends, welcome back to my new video on my channel, and this is the part 3 and the final and the concluding short video on the pancreatic stone protein. And here we will discuss a bit of the meta-analysis and what exactly the PSP or the pancreatic stone protein is offering us, and whether can we really use it in the real time scenario in the present day context. So this was a meta-analysis published by Prazak et al. In the Critical Care 2021, so not very old, and it talks about the PSP for the diagnostic of infection, individual patient level meta-analysis, and you could see that there were about 600 patients, and these are the various studies which were kind of included in the meta-analysis. And the goals were to determine the performance of PSP in detecting infection, to propose a threshold value for that purpose, and of course to validate it across the heterogeneous population. So here we are not only looking at one particular subset of sepsis patients. And as you could see that the PSP cutoff value was 44.18 nanograms per ml, and these were the cutoff values for CRP and PCT respectively. And as you could see that the specificity and the sensitivity ratio of this particular kind of biomarkers, if you see, then you could see that there is a fairly high specificity and the sensitivity of PSP as compared to the CRPs and the PCT. So as you could see that this PCP or the PSP, which is a continuous line, there's a fairly high sensitivity and specificity as compared to the dotted line and the PCT, which is the black dotted line. So we know the prognostic kind of value of PCP, and it is of a questionable benefit whether it will really have some kind of prognostic value. And it is published in the respiratory critical care medicine 2019. So it was a questionable kind of benefit. And of course, whether can it be used as a marker of organ failure and outcome in VAP. And as you could see that the sensitivity and specificity of PCP, which is fairly large as compared to others, and here we can actually have this kind of patients in our ICU where whether the doing a PCP can really help us. So this was another paper in Critical Care Medicine 2013, which kind of discussed the prediction of outcome in patients with peritonitis in ICU. So these are the three different graphs of organ failure, the multi-organ failure, and the deaths in ICU. And we could see that the p-value was statistically significant. And the pancreatic stone protein as an early biomarker predicting mortality in a prospective cohort of patients with sepsis requiring ICU management. So this was the PCP, and this was IL-6 and the PCT, and this was actually the PSP. And as you could see that the PSP has extremely high value, which is actually correlating with IL-6 in terms of predicting the probability of hospital mortality of the patients. So as far as the prognostication of mortality in critically ill patients with severe infections are concerned, here we could see that the institution of the Apache 2 and the SAPS-2 scoring, which is done in this particular paper, which was published in Chest 2015. So what is the take-home message? I think that the message is that it is not affected by non-infectious inflammatory processes, and this is very important. PSP indicates the presence of infection in various patients, and we saw right from cardiac patients to the trauma to sepsis with multi-organ failure to burns and to patients with post-abdominal surgeries. It may indicate the likelihood that the infected patients will develop organ dysfunction eventually, and that is again a very vital information which anyone can get. And it will, of course, identify the patients with high risk of death. And how can one look at the PCP is with the point of care measurement with a nanotechnology which is offered by a bionic system, and as a real time or the real life marker, as you could see that when a lab parameters will give you the real results in the intensive care, where the patient can be at a risk of sepsis right from day one, to the clinical decision of antibiotics to mitigate the problem of sepsis, where the PCP can still be of help, and a clinical decision to de-escalate or not will be of crucial benefit. So these are the serial measurements of PCP for early detection of sepsis in intensive care, and this was a Pugin et al. Paper published in Critical Care 2021. Again, these are the serial measurements with the CRP, and as you could see that the sensitivity and the specificity of PCP along with CRP holds quite intriguing, and it is quite encouraging kind of data. So is it an ideal biomarker? So yes, it can be available as point of care innovative nanofluidic technology. It can be used to diagnose sepsis early, to stratify the patients according to the severity, and of course evaluate the risk of mortality. So its performance to diagnose sepsis in real life on ICU was confirmed by a recent prospective study. And as I said, we as intensivists may not be really dependent 100% on a biomarker. We need to actually send blood cultures as a conventional traditional method of diagnosing sepsis in almost all the patients in whom you suspect a sepsis. There is no replacement of blood cultures to the other tests like biomarkers or the multiplex PCRs. Having said that, it can, I would say, at this present point of time, help us in having these three important kind of benefits for any patient who comes to you in ICU. I hope I have given a very clear and a very kind of a message which can be helpful for you to treat the patients of sepsis in your own ICUs. That's all for now. Tata, goodbye, and take care of yourselves.